and I think it's time to introduce Harry Janssen. Most of you will know Harry. He's the chair of hepatology at Professor of Medicine at the University of Toronto. He is chief of hepatology and director of the Toronto Center for Liver Diseases, and his leading role in hepatology, and in particular viral hepatology, is probably indicated by that his publications have been cited more than 45,000 times by the community. Harry, we're looking very much forward to your talk.
Thank you very much, Ulla. I hope that everyone can understand me well. First of all, my congratulations also to Mike Houghton, Charlie Rice, and Dr. Alter for getting the Nobel Prize for hepatitis C. And let's hope that, just like hepatitis C, we can make hepatitis B a curable disease as well. That's what we're currently working on. So my task is really to look at this problem of the different biomarkers from a bit of a different angle. I'm a clinician scientist, so I will try to go through the use of these different biomarkers in the natural history, but also in the treatment of chronic hepatitis B. Here are my disclosures. So the ideal biomarker should be obviously predictive. It should have a high specificity and sensitivity. It should be reflective of a durable response. Mostly, it should have a high reproducibility. It should be non-invasive, rapid, and cheap. So there are many biomarkers being used, mainly in an academic experimental setting, but I really want to focus on these three. Quantitative HBS antigen, which has now been used in clinical practice for roughly, say, the last decade, the last 10 years. In the past, we mainly used HBV DNA at the time of the antivirals. Which is more used as a quantitative marker. I would say in most countries now we have quantitative hepatitis surface antigen as well. In addition to that, I'll focus on HB correlated antigen and HBV RNA. So if you look at the natural history, just to go back, and with the biomarkers that we currently use in clinical practice, you see that there are different phases and there are different biomarkers, HBV DNA, S antigen, and ALT, and you start off with an immune tolerant phase, which I'm not allowed to call it like that according to the immunologist, but still in the clinical practice we use it because it depicts really a setting of very high viral load and high S antigen levels and no inflammation at all. And typically when you're infected over a couple of decades, we think that the immune system sort of wakes up even more than an immune tolerant phase and starts to battle the virus, where you see an HBV DNA drop over time, over many years, as well as an HBS antigen, which goes a bit slower. And that goes along with an ALT increase, indicating basically that we think that the immune system is kind of battling the virus and trying to get rid of it, but very often unsuccessful. So up until many decades later, where we hope to get immune control by in E antigen negative carrier state, I would say, and later on, hopefully even S antigen negativity and cure. So let's look at HBS antigen. Let's see if we can read this. So how useful is S antigen quantification? Definitely HBS antigen loss is associated with a better outcome. Less cirrhosis, HCC, and mortality. I'll tell you something in a minute about HCC reduction. We know that we can use S antigen as a good marker, as a relatively good marker to distinguish in E negative patients who have active and inactive disease, which in clinical practice is sometimes a challenge. And if the S level is low, there's much more evidence that this disease is really what we would call inactive. S antigen thus far is the best predictor for prevention of relapse after stopping treatment. There have been many studies done with other biomarkers, but thus far S antigen, low S antigen has been the most best well reproduced here, I would say. It is a good marker for PEG interferon response. I've published many papers on response-guided therapy. S loss is a very stable endpoint. off treatment for both PEG interferon and nucleoside analogs, and therefore used as a functional cure of the new treatment trials. The problem, we think, however, that in E-negative patients, as already mentioned, S production is largely driven by integrated HBV DNA and less so by CCC DNA. In other words, the question is, do we really need to get every patient S antigen negative to get a cure? So here, if you look at the HCC prediction, just like in HBV DNA, it's been shown that higher S levels are independently associated with HCC development. And among patients with low, medium viral load, higher S levels independently predict HCC development. And there's an enhanced performance if it is combined with HBV DNA. The problem, however, is that S antigen is not used in every country. For instance, in the US, it's not reimbursed, in some other countries as well. And S antigen is not quantified, so therefore it's not really used in many prediction models. So what happens to S antigen if you would give one of the newer treatments? Here, a recent study from Ed Kane, where small interfering RNA was given to patients with hepatitis B. And there you see, and this is really something we haven't seen over the last decades with any of the conventional treatment, a quite dramatic S antigen decline just with 2 injections here. So this is a phase 2 study. And we see like a 1 to 2 log decline of S antigen. And in fact, most patients develop S levels which are rather low. And hopefully that could be, I would say, the initiation of cure. The question, however, is this an effective S antigen decline, or is this a rather artificial S antigen decline where you might drive the S antigen down with the specific targeting treatment, but once we stop it and the patient might even be S antigen negative, it might pop up again. So the question is, does this really cause an immune response which would be effective and get an off-treatment sustained response? There is some evidence on that, because there's another study presented by MFUN where they used an antisense oligonucleotide recently from GSK in this case, where again you see a very profound and quick S antigen decline, and this time accompanied in several patients by a flare, which could suggest that driving down the S load just by itself might induce an immune response, which hopefully could be effective. This is all to be sorted out further, because it really decides whether we can just move on with antivirals or whether we should use combination therapy with antivirals, as well as with immune modulating drugs in the future. So what about HB correlated antigen? It's, as already mentioned, it's a combination of HB core antigen, HBe antigen, and the 22 kilodalton pre-core protein. In E positive patients, it's highly dominated by E antigen. If you look at E antigen quantification, you can just put the curve on top of HB correlated antigen. So there it is potentially less useful. HB correlated antigen is a surrogate marker, we think, for both intrahepatic CCC DNA and its transcriptional activity. It can be useful in the evaluation of antiviral therapies aiming at functional cure of hepatitis B, either by targeting directly or indirectly CCC DNA pool. It's been associated to current antiviral therapy with the antigen positive disease. And there's been lots of studies done with correlated antigen by Fuji Rebio, also to kind of push this biomarker on the market. But still the sensitivity, I think, would need to be improved. It's currently 3 logs. And the question really with all of these biomarkers, and I'll come back to that at the end of my talk, is that which one is better? How do we distinguish these different biomarkers, and how do we use them in the way they would be most useful, I would say. So if you look at the natural history, really, if you look at correlated antigen, it is highest in E antigen chronic infection. So this is the immune tolerant state. And then it goes down if you basically become E antigen positive active disease. And if you become E antigen negative, you see a profound decline in correlated antigen. And if there's still infection, if still inflammation there, it's higher than when there's really no inflammation anymore. and patients are in an inactive E antigen negative state. So correlated antigen is higher in E positive versus E negatives. There's a potential use in distinguishing between inactive carriers for E antigen negative and active disease. It's limited by the sensitivity of the assay in particular. What about correlated antigen HCC prediction? That has been shown to be useful, but again, we don't know if it's more predictive than the other factors that we're using. Definitely high baseline levels are associated with higher risk of HCC development in treatment-naive patients, and it's claimed to be superior to other biomarkers in its predictive power, but there's different studies on that, I say, with conflicting results. Persistently high on treatment correlated antigen levels independently are associated with a higher risk of HCC in new treated patients as well. And it's been recently reported that if you have detectable levels of correlated antigen after 2 years of nuke treatment, that there would be an independent risk still for developing HCC. What about HBV RNA? I'm just giving you a few data because there have been many studies published on all of these biomarkers, and this slide or this figure here on the left side was already shown. Again, the pattern is very much the same as for the other biomarkers, that HBV RNA is highest in the IT group, and then lower in the E antigen positive active group, and again lower in E antigen negative patients. There is definitely a strong correlation of this compound with CCC DNA transcriptional activity. As already mentioned by Florian van Bommel, the HBV RNA, but actually also correlated antigen are influenced by other factors. So here you see in a study that we did a few years ago, the correlated antigen, the HBV RNA levels together with the group from Florian van Bommel, and looked at it in different genotypes where you see small differences. Also the presence of basal core promoter and pre-core mutations give different HBV RNA levels, and particularly again positive versus E positive versus E negative groups. Also, the HBV RNA tends to go up a little bit in patients with more inflammation. So I would say for HBV RNA, the usefulness and prognostication of the natural history of chronic hepatitis B has been unclear. There's a paucity of data on its predictability of HCC development. That's mainly due to the fact that just less studies have been done with HBV RNA than with correlated antigen, but I think it definitely could be used for that. Measurement of serum HBV RNA can be used to monitoring viral dynamics of HBV DNA negative patients under treatment potentially, because that's where its strength really could be. Pre-treatment HBV RNA is associated with response to nucleoside analogs and peg interferon alone, as well as in combination. It's claimed to be useful to predict response after stopping, and particularly in undetectable HBV RNA, together with an S antigen level of below 10 would be very predictive. But again, if you look at those studies very carefully, only a very small segment of patients have this particular pattern. So then again, it's we have to see whether this is useful in the clinic. Where I do think that HBV RNA measurements are particularly helpful is monitoring the effectiveness of drugs aiming to affect CCC DNA transcription or pgRNA stability. So in particular, the capsid inhibitors, which target the nucleocapsid, there, as I'll show you in a minute, you see a profound decline of HBV RNA, and there the marker is definitely superior to HBV DNA. Here, I would also say that the sensitivity should be improved, at least the sensitivity to claim, let's say, functional cure. If we look at our studies where we, for instance, monitor patients who are E negative for a long time in a long-term nucleoside analog therapy, and we're giving them another drug hoping to cure them, we see that already if these patients are treated with long-term nuke and E-negative, 70–80% of the patients are HBV RNA undetectable, and therefore it could not be used. So in part of the E-negative patients where HBV DNA is already suppressed, HBV RNA could be used, but in many, in fact, we cannot, because the sensitivity is not enough yet. And I know the companies, particularly Abbott and Roche, have done a phenomenal job to improve that, but it's still not optimal, unfortunately. So how do these HBV biomarkers compare? That is obviously the multi-million-dollar question here. And if you look here, it is important to say that different biomarkers perform differently for different drugs if you look at treatment. So this is a study that I presented recently at the EASL, where we used the CAM in combination with a nucleoside analog. And here on the left side, you see HBV DNA reductions in patients who have not been treated before. So these patients were not suppressed by an antiviral before they were started on the CAM. And then if you look at the HBV DNA, whether you're giving monotherapy with the nuke, which is in gray, or whether you're giving the combination therapy with the nuke and the CAM, you see that roughly similar HBV DNA declines happen. And this is both present in the E-antigen positive as well as in the E-antigen negative group. Now, if you look at HBV RNA reductions from baseline here on the right side of this slide, you definitely see a profound difference in patients who are treated with the CAM and not. So if you're treated only with a nucleoside analog, you see a very modest decline. But if you add a capsid assembly modulator to it, you see a much more profound decline. This is in patients who have not been treated before, and you see kind of a similar difference in patients who are virally suppressed. And here it just doesn't go down that much because the HBV RNA level is already very low in these particular patients at the start. And the same can be said about small interfering RNA, which give a very profound S decline, as well as the decline actually of HBV RNA, DNA, and all of the other biomarkers. And you won't see any S antigen decline or hardly any with the capsid assembly modulators or with nucleoside analogs. Here's another example where you can compare the different biomarkers. This is a study also presented at the recent EASL meeting, where entecavir with the capsid assembly modulator was used, in this case GLS4, in E-positive patients. And again, patients were treated with an entecavir alone or with entecavir and the capsid inhibitor. And here, the nice thing about, and this is the reason I'm showing this picture, is that here you can compare the different biomarkers on this specific treatment over time. So if you look at the HBV DNA here on the left upper panel, you see that both in the entecavir only as well in the combination group, it goes down. If you look at correlated antigen, you see a bit more of a divergence between the two different treatment modalities. And if you look at pregenomic RNA, it even gets bigger over time. So here you see how these different biomarkers perform. This is in virally suppressed patients, the same picture with pregenomic RNA, a profound decline again with the CAM, which obviously targets the nucleocapsid. So how do these different markers predict treatment response? And I took the model here of PEG interferon because it's obviously not used a lot, but the good thing about PEG interferon is it's kind of a good model for us. Now we're moving into new treatments trying to get cure of disease. And here's a study on the left side done by Florian von Bommel, on the right side study done by my own team. And what you can actually see, and this is here for E-positive patients, that if you look at the different biomarkers and really the predictability of response, so the area under the curve really, in this case, S antigen did do better than HBV RNA as well as HBV DNA and E antigen. The differences are not huge, but it's there. Here, again, this is PEG interferon treatment and again predicting response. And this is really the area under the curve. So we look for each biomarker on their predictive value really for response. And if you look overall, there's not much different, but quantitative S seems to stand out and is definitely better than HBV, or it's somewhat better than HBV RNA. A similar pattern we saw with correlated antigen, which is definitely associated with treatment response for nucleoside analogs plus or minus peg interferon, both in e-antigen positive and e-antigen negative chronic hepatitis B. So if you do a study like you'll find an association. That's what people typically report. What people sometimes do not report is how they compare to the other biomarkers. And in our hands, correlated antigen was definitely not superior to S antigen in predicting response to therapy. So that's something to be that I think is important to remember. So in conclusion, ladies and gentlemen, I think that e-antigen, quant S, and HBV DNA will likely remain to be the most important biomarkers used in the natural history and treatment endpoints because they are best validated to reflect the outcome. And biomarkers have different importance in different disease phases and different E-positive versus negative genotypes, but in particular for different treatment modalities. So that we have to be very careful, because if company X develops a drug which particularly favors one of the biomarkers, this is what they will look at basically, and sometimes advertise with. And definitely they're doing a phenomenal job and are very honest and objective and give all the other biomarkers, but sometimes I've seen the tendency that a particular biomarker is preferred. So if you look at HBV, RNA, and correlated antigen, they are definitely related to the outcome of current new therapies, but may not necessarily better predict the outcome than quant S. HBV, RNA, and correlated antigen tests need to be well validated, and their sensitivity needs to be optimized. And I would say that these biomarkers are still very important, let me be very clear, particularly to dissect the mechanism of action of new drugs. So they're highly useful in phase 2 studies to see where the target engagement is. In phase 3 studies, my thought is that we will rely more on S antigen levels in HBV DNA. So I'd like to thank Hannah Choi, who helped me preparing this presentation. I'd like to thank you for your attention.
Yeah, thank you very much, Harry, for this really comprehensive overview. I would suggest, as you also participate in the panel in a minute, we just take the one question which came in via the chat before I then hand over. And the one question is from Keizuke Fukutomi. And the question is that regarding that S antigen is largely produced from integrated DNA, is S antigen really a good marker for HBV cure? So inhibition of CCC DNA activity, in particular in e-antigen negative patients, or do you think HBV RNA or correlated antigen may be better markers?
Yeah, so that's a very good question, obviously. Definitely S antigen, if you put the bar very high, S antigen loss is the best biomarker. It's if you have it, it's always good. That's a certainty. The question indeed is, could we have a sustained off-treatment response and cure, particularly in E-negative patients with S positivity? And the answer is yes, we could. But I would say HBV RNA and correlated antigen definitely don't fill that gap yet, because we've seen that if these biomarkers are undetectable and we stop treatment, that in many patients, at least with the current treatments that are around, licensed, but that many patients relapse anymore. So I definitely agree that S antigen by itself would not be enough, and there might be many patients who are cured that we don't find. Definitely, if you have S antigen negativity, it's always good. But I'm not sure that with the current sensitivity, HBV RNA and HB correlated antigen would fill that gap.
Yeah, thank you very much. I'm sure there will be more about that in the following panel discussion. With that, I'd like